Welcome, everyone. It is my absolute pleasure to welcome you to the Social Outcome Conference. For people that are joining for the first time or are veterans of the conference, we are so grateful that you're here, and we're really happy to continue to share learnings and collaborative practices. My name's Emily Hulse. I'm a researcher here at the Government Outcomes Lab here at the University of Oxford. I am the chair of this session, which is titled Benefits and Challenges to Outcome-Based Finance for Health. If the clicker works. Next slide. Perfect. So just some housekeeping notes. We are here live from the Blavatnik School of Government in Oxford, as well as online in Zoom. So if you're joining in person, you can still join Zoom, but please keep your speakers muted. We'll stop throughout the session to take questions, both from online and in-person participants, so keep writing your questions, keep writing the questions in the chat. All sessions will be recorded and shared on the GoLab website. And the GoLab team is ready to help you for any concerns, questions, and reflections you have. I am joined by my fabulous colleague, Felix, who will help with any questions and passing the mic, and also Maria for the online participation. So meeting our speakers, we are joined by three fabulous speakers, as well as an additional panelist. So firstly, we have Blavatnik from Syrian Research Institute. He is a esteemed professor, as well as a esteemed researcher from Invest for Health. He's joined by his colleague, Stefania Planko, who's a junior researcher and a graduate student, also at the Syrian Research Institute and the Horizon Europe project, Invest for Health. Next, we have Henry Cutler, who is a director and professor at the Macquarie University Centre for Health Economy. He's also a visiting researcher and professor at the Nuffield Department of Primary Care Health Science. Is that right? Wonderful. And finally, we have Ruben Kuki. Perfect. Who is the co-founder and managing director of Social Finance Netherlands. Perfect. So the organisation of today will be three parts. So firstly, I will introduce outcome-based financing for health for anyone who's unfamiliar, and also introduce our key case study, which is the MHEP, or Mental Health and Employment Partnership. Next, we'll have the speakers' deep dives into three different evaluations, one from Europe, or across Europe rather, one from Australia, and one from Netherlands. And next, we'll be having a panel Q&A. Perfect. So an overview of outcome-based financing for health. Perfect. So I'm sure a lot of us are well aware of this, but over the last few decades, most healthcare systems around the globe have experimented with the approach they pay providers, particularly with regarding to attaching financial incentives directly to quality of care and performance. Previously dominant financing systems, such as block grant contracts, fee for service, means that providers are responsible for delivering pre-specified services, but not necessarily incentivized for achieving outcomes or high quality care. So there was a premise or a theory that tying partial or full payment to measures of outcome achievement could be seen as a way to reduce perhaps misaligned incentives and drive quality of care. Perfect. So just so we're all clear on definitions, this leads to outcome-based financing definition, which is the financing or funding of programs contingent on the achievement of outcomes, and social impact bonds, which is a common subset or category of outcome-based financing, where private investors provide the upfront capital to cover service delivery setup costs. Here at Government Outcomes Lab, we also can call them cross-sector partnerships or social outcome partnerships, where basically organizations come together collaboratively in the pursuit of better social outcomes. So here is a very, very basic structure of a social impact bond for those that are unfamiliar. And I will say that there are numerous other structures. So feel free to correct me and tell me the different varieties that you have experience with. But firstly, the private investor at the top of this diagram can provide the working capital. And often this is flowed to a special purpose vehicle or a social impact bond issuing organization. Then the funding for operational costs is flowed to the service providers. The service providers has perhaps flexibility and innovation to deliver their service. And once these pre-specified measurable outcomes are achieved, this is when the performance-based payments are flown from the outcome payer, typically local commissioners or national government here in the UK, flow these performance-based payments, which allows the repayment to the necessary parties as well as a return on investment. Perfect. Now here at the Government Outcomes Lab, we have the world's only open access data set to all outcome-based contracting and impact bonds in the world. So from this data set, I have found some statistics here today to look at really the kind of taxonomy of health impact bonds thus far. So far, there are 51 social impact bonds predominantly focused on health. 65 if you also include the intersection between mental health and employment. The most common health services that are funded under these social impact bonds currently or so far are mental health with 15 impact bonds, followed by reproductive and maternal health, elderly mobility and end-of-life care. And so far, they're adopted in 19 countries and counting. So this doesn't just include developed or high-income countries, but also low-income countries as well. We have found that the most common metrics used for these projects where the outcome is contingent on this payment include increased health service uptake, as well as improvements in equity of access, improving of direct health outcomes, particularly for diabetes or cardiovascular disease. There's improvements in quality of life, particularly when it comes to care, improvements of self-management of condition and also health literacy. We have also the organizational level, we've got service quality improvements and health infrastructure. And additionally, we've also got some targets on the social determinants of health. So it is a health program, but the outcomes tied to payment are also about learning outcomes, education outcomes, work experience, or housing retention. So next, I will introduce a key case study, which is the Mental Health Employment Partnership, to really introduce this story arc of benefits, challenges, and solutions. So the Mental Health Employment Partnership was established in 2015 to drive the expansion of an evidence-based intervention, which is individual placement and support, or IPS. It is a special purpose vehicle or a platform run by Social Finance UK, backed by social investment from Big Issue Invest. Within the Life Chances Fund, which is a DCMS-housed or UK government-housed outcome fund, the Mental Health Employment Partnership supports 5 key impact bonds, all in kind of London boroughs. The service that it funds, as I said, involves the integration of employment specialists within clinical health teams to optimize mental health patients to return to work, to return to society, to be integrated and embedded. IPS services do not exclude people on the basis of diagnosis and have the principles of zero exclusion, unlimited support, and integrated services. Through this MHEP social impact bond design, there are 3 main outcomes that are tied to payment. This includes engagement, which is when an individual engages with the IPS program and completes a vocational profile. Secondly, there's a job start, so the individual has to spend 1 full day in paid competitive employment. And lastly, job sustainment, where an individual sustains paid competitive employment for at least 13 weeks. And as you might be able to see, it is a kind of outcome chain of short-term to long-term. And this weighting of payments is also reflected in that. So here we can see a diagram which actually shows the blending or combination of national outcome-based funding through the Life Chances Fund, Outcome Fund, with local funding and social investment to grow and scale IPS in the UK. Here we can see the numerous different actors within the social impact bond. So we've got social finance as the intermediary and co-commissioner, which is really managing the performance and the contract of the social impact bond. We also have Big Issue Invest as the investor. We have various providers, including a Working Well Trust, Twining Enterprise, Jet, and Enable. We have local commissioners who are predominantly local authorities, so London councils, as well as clinical commissioning groups. And as I said, Life Chances Fund, which provides a minority contribution to outcome payments, really to support the local commissioners in topping up outcome payments. So the Government Outcomes Lab have been fortunate to be commissioned by DCMS to evaluate social impact bonds under the Life Chances Fund, of which MHEP is included. And so we've run a longitudinal study for a few years. And this current round of evaluation, we've interviewed around about 30 interviews from the commissioners, the providers, the investors, as well as social finance staff. And I hope to share just a few key highlights on the benefits, challenges, and solutions to some risks. So the major benefit that we found in MHEP was increased accountability. So there was a perception of greater accountability in the SIBs compared to traditional funding of IPS or the historical contracts of IPS that the providers were under. However, what was really clear from the interviews is that they wanted to emphasize that this was because of improvements in the way that they commissioned or commissioning practice, rather than the kind of punitive enforcement of the payments. So the accountability for improvements in commissioning practice occurred at sort of four main levels or four main reasons. The first was increase in monitoring and continuous monitoring. Due to an outcome-based approach, there was obviously a higher focus on data monitoring. And so the ability to be provided with very bespoke and very granular detail of what was working in the service, how could they improve, at which frontline staff was doing the best, and how could we learn from. That was a key improvement in the service. The second one was more contractual levers to respond to underperformance. So in traditional contracting and commissioning with local authorities, they actually found that they didn't necessarily have many penalty clauses for underperformance. However, with the use of outcome payments, it was a way to respond to underperformance that was very clear at the provider level. Thirdly, we also have high commissioner involvement. And so the commissioner under MHEP, as well as the council and the clinical commissioning groups, had a remarkably increased engagement with the providers, with quarterly meetings and regular calls to ensure that the success of the project was everyone's goal. And lastly, what was clear from increased accountability was active problem solving. So underperformance isn't because of a moral failure of the providers, but actually a root cause of perhaps external issues, perhaps workforce development. How can we support providers for better social outcomes? The main challenge we found, which may not be surprising to many people under the MHEP project, is complexity. And a lot of the times we can say that perhaps this is unfamiliarity of the social impact bond model. However, what we found is that there were kind of four main reasons for this complexity. The first one was the local variance of commissioner preferences. So as we all know, when we design a social impact bond, we have to pre-specify these measurable outcomes. However, different commissioners at different levels may have different preferences of definitions, thresholds, targets, as well as what they're willing to pay. And so that can add an added layer of complexity. The second one is a lack of clarity on the reasons for payment flows. So providers, particularly frontline staff, need very dedicated upskilling of what a social impact bond means and why are we doing this. Thirdly, analyst interpretations and financial modeling. I'll get into this a little bit more, but there is a difficulty to predict social outcomes, and how that affects the ability to forecast at the local government and national government level can be a source of complexity and difficulty. And lastly, turnover. So in terms of local variance of commissioner preferences, we can see, a quote here from the social finance team of the ecosystem is more complex because there's a lot more commissioners. There are providers in different areas with different needs, and each site can be set up differently because of that. And so the people that are managing the social impact bond has to manage all these different variations and be able to be across all of them. Secondly, with a lack of clarity. So there's definitely an admission from the social finance team of we still haven't fully cracked to remove this confusion completely. However, they're continuing to learn and adjust these kind of set up knowledge exchanges to understand why. Thirdly, with the analysts' interpretations and financial modelings, so we have a MHEP manager here who stated, the financial models are different for each SIBS and they have different rules and they've existed for 5 years. And so many stakeholders have contributed them to over the years. And so that can cause a source of difficulty. And it's certainly an upskilling thing for the social impact bond contractors. And lastly, turnover. Obviously, a social impact bond should be about relationships. And if there is a high turnover of staff, that can affect the ability to performance manage under this approach. However, it also means that this clarity issue can also be highlighted. However, not to fear, we have some solutions, and there were 4 main solutions that were suggested by our interviewees. So firstly, ensuring early buy-in. This is not a surprise, it's very common sense, however, it is easily forgotten. So early buy-in for the principles and design justifications for social impact bonds is needed, and reminding new members if there is turnover. Secondly, acknowledge that adaptability and a learning mindset approach is essential in dealing with unexpected events such as NHS transformation or COVID-19. Thirdly, acknowledge that the challenges in forecasting outcomes, particularly in complex social areas of need, and recognise that these can fluctuate over time. And lastly, address the issue of annualised payment caps in outcome-based partnerships and outcome-based contracts. And this perhaps may not be compatible with the requirement to spend in line with forecasts. So unsurprisingly, many emphasise that action taken at the start of the contract would alleviate these perceived complexity and communicating the rationale. So we have a reflection here of a provider that it took them about a year to properly get used to and really understand the mental health employment partnership. The other main challenge was incentive. So MHEP SIBs, theoretically, are expected to operate under strong traditional financial incentives from outcome payments. However, the financial incentives were quite muted, more than expected, for 4 main reasons. Firstly, the absorption of the outcome targets. Secondly, because of the provider's greater intrinsic motivation. We also have a lack of direct payments to the frontline staff who are actually causing and leading the outcomes. And lastly, a lack of clarity. So if many frontline staff don't comprehend the amount of payment or the need to provide evidence, then surely they may not be as motivated to get that payment. So in terms of outcome target design problems, as I said, providers did not internalize some of the performance targets, especially if they were deemed too high or perhaps too infeasible to achieve. Next, with greater intrinsic motivation, the frontline staff in provider organizations were unsurprisingly very client-focused, specifically because it's a vulnerable population of severe mental illness, particularly people with psychosis or severe depression. And so provider leadership teams actually found the need to shield their frontline staff from the outcome targets or from the pressure of the outcome targets so that these specialists could really focus their energy on delivering IPS well. So the managers within these provider teams made a conscious choice to absorb this pressure. Next, in terms of lack of direct payments, the frontline staff weren't directly rewarded for outcome achievement. This was to the organization. So there was a sense of diffusion of this incentive. And lastly, the lack of clarity. Not to fear again, we have some solutions suggested by interviewees to incentivize the right way or to improve this incentivization. And this is really based on kind of self-determination theory for any psychologists out there. So the first one is for the MHEP intermediary or the social impact bond managers to really tap into mission pride and really start to recognize and bring the relatedness back into management. Secondly, tap into this idea that there's perceived efficiency gains under a social impact bond, that the providers can then gain more autonomy. And lastly, tap into personal best and this ability to enhance competence. So I'll just briefly touch on those main 3 points. So firstly, personal best. So by comparing providers' performance to their personal best, this meant that the MHEP could set perhaps more realistic goals and provide more personalized positive feedback. This also encouraged providers' team to be empowered and to view themselves as competent. We can achieve this because we have achieved it last year. Let's try and generate effort and time to that achievement. In terms of autonomy and perceived efficiency gains, so MHEP's clarity of data requirements that meant that providers' processes and data systems were improved, and that was something that both commissioners and providers felt. So if we can ensure that, hey, we know that this social impact bond can be a bit burdensome or it has a bit of a learning curve, but we're creating efficiencies here. We're creating new data systems. This is hopefully going to motivate frontline staff and believe in the power of this approach. And lastly, tapping into mission pride or trust. So building trust between the team and the providers. Oh, pardon me. Should be still working, I believe. Was seen a successful motivator. And this is when MHEP could align the values of IPS with the values of their organization. This is also about recognizing providers' intrinsic motivators and their own tacit knowledge that they are the experts in the clients. We are not the experts. We are just supporting them. How can we support them? How can we build this trust? And providers were split into advocates and skeptics of future outcome payments. However, most were in favor as long as they could keep this collaborative approach, this trust-based approach, but also when outcome payments were a low proportion of contract value to manage risks. Next, I'll pass on to Stefania, who will really deep dive into some of the benefits of outcome-based approaches.
Hi, everyone, and thanks, Emily, for the introduction. I'm really glad to be here. And I'm in behalf of Syrian Research Institute from Budapest, and in the next couple of minutes, I'm trying to give you an insight into what we believe are the potential benefits of outcomes-based financing in health promotion and disease prevention. And I also like to thank my colleagues from Syrian, also from the University of Oxford, Bangor, and Erasmus University for their kind contribution to this project. Yeah, does it work?
No, you just...
Okay. Thanks. So just to provide a background into the project, it is a Horizon Europe project called Invest for Health, and the key objective was to explore novel financing models that can decrease the burden on public budget related to any investments in health promotion and disease prevention. We began with a literature review to uncover these different investment models, and also conducted many expert interviews to explore these models further. And from these 2 elements, we designed an investment model inventory and also a value matrix. And the investment model inventory's key purpose is to find the decision makers' priorities in health investment and combine it with the universal or general promise or universal or general promise and aim of healthcare investments. One thing to add that all the results that I'm going to present are from the midterm point of this project, so it's work in progress. Yes, so next slide. And another thing to add, in terms of the research, it is worth noting that there is a considerable body of literature on social impact bonds related to prevention, in health prevention. However, we lack examples related to other outcome-based financing models, as you can see in this graph. So consequently, the results that I'm going to present are mainly based on social impact bonds. Next. And now let's turn our attention to this, to the benefits, the potential benefits of outcome-based financing. We categorized into three groups. One is outcome-related benefits, another is financial benefits, and the third one is system-level benefits. Yeah. And what I like to underline is that we also recognized challenges associated with social impact bonds, but that's a topic for another speaker, so I will leave that to the guys. And now let's turn to the outcome-related benefits. One is that it maximizes the flexibility in service provision because contracts do not specify how to achieve outcome. Another is that SIP schemes are a good breeding ground for a culture of monitoring, as also Emily highlighted in his case. And it's due to the intensive collaboration and the continuous evaluation of performance. To underline the financial benefits, one is that it generates financial stability for the service providers. Yes. And the other is that it provides cost saving for the government. So generally, SIP schemes promise governments to provide cost saving on the long run, in the long run, if they invest in early intervention programs that deliver social value. About the social system level benefits, one to highlight is that it favors evidence-based policymaking and enhances accountability because more data collected leads to accountable programs and accountable parties and more transparency. And lastly, the combination of the different previously mentioned elements is that governments can test with pilot programs with the SIP schemes, and they can gather evidence that future policy decision makers can use to make decisions with greater confidence in any health prevention cases. Yeah, now while the previous slide focused more on the theory, this one has a more practical side. We are now developing in different investment models for each test bed in this Horizon Europe project. And this value matrix has the purpose to highlight what are the interests of the different decision makers in health promotion and disease prevention investments. And it is also actually connect to the opening remarks of the panelists, like what is in the tip of the iceberg and what is the position of these decision makers and what are their interests and where can we see any connection yes. And this value matrix is not mutually exclusive nor collectively exhaustive, and it's still work in progress. But we are trying to use it to discuss with the test beds and the different stakeholders in the test beds how can we design the best health promotion and investment that can balance the health and also the financial outcomes. Yes, and the discussion. The theory highlighted several benefits related to social impact bonds and outcome-based financing. But however, our results showed that these benefits are limited by practical challenges. And one is that, for instance, social impact bonds are seems to be less effective for large-scale health programs in primary and secondary prevention. And my question is for you and for everyone is to just think about it. Could it be that the SIPs and social impact bonds are not being used widely and not that successful as we expect because we are using it in the wrong context. And I propose that should we focus on using them in, for instance, tertiary prevention instead with the more well-defined target groups. Yes, and thanks. I would like to give the
Perfect. And on the next slide, we should have a question to audience. So this is an opportunity, very short opportunity, to quickly engage and understand what were the key takeaways that you've learned on the benefits of outcome-based financing for health. And if anyone wants to raise their hand for reflection on any experiences that they've had that this sort of key information has resonated with you. Yeah, of course. Sam, would you mind doing that as well? Thank you. Otherwise, if you just type in slido.com, the password should be hashtag SOC24. Yes, fifth.
Thank you. My name is Grace Duffy. I'm from Bridges Outcomes Partnerships. And we do a few kind of projects like this in healthcare. I was wondering if you could expand a bit on what you talked about, the kind of the transfer of risk between different parties and away from the commissioner. I was wondering if you could talk a bit more about that and how you found that works and how that's communicated amongst different parties. Because I think in some times when we're engaging with sort of I think that kind of risk transfer aspect can be understood differently by different parties and is perhaps viewed with some suspicion by kind of some. And then just a bit of a reflection, I think, from our health programs is that I think one of the real constraining factors when we've tried to deploy these is around the budgeting and is the sort of the fragmentation of where budgets are held in the UK context, where you have like multiple different players, all with slightly different responsibilities, but none of them with a real incentive to invest in prevention. And so I think that is one of the real constraining factors in doing these kinds of health, SIB work at scale in the UK, at least.
Perfect. Thank you so much.
I would like to ask you to just repeat the second part, just to be clear if I understood it correctly, but related to the first question, our results, so risk transferring seems beneficial for the government, that's for sure. However, it's less, it seems from these different resources that it seems less fair to the investors because they are putting their money in these investments. And if the outcomes or the measures are not designed well or the measuring not designed well, then what does it worth to risk this? And actually, we don't really believe in this from our results that it's an advantage of this scheme and more of a drawback. But maybe others have other experiences. And I don't know if Balázs would like to add something. Yeah, and what was the other part of the...
Sorry, there was more of a reflection than a question, but just one of the challenges, the constraining factors in the UK is that, in any particular area, you have multiple different players with different budgets, often on different timelines, and it's all structured around dealing with sort of presenting problems in primary care, and actually the lack of incentives for commissioners and budget holders, firstly to collaborate and to pool their funding, which is really what we need, but also to invest in that long term. There aren't really those incentive structures in place for budget holders to do that. And so that's one of our big constraining factors. It's a real challenge of how to get across that. So, any ideas in the room also always welcome.
Perfect. I'll just pass on to Maria if she can share some of the results of the Slido. So here we've got primary and behavioural integration, I believe. SIB's not worth it. Love it. Let's bring the passion. Person-centred care, shared vision, learning, monitoring, risk sharing of the long term, Outcome-based contracting has worked in health, so a few experiences here of some positive examples. Perfect. Now, I think we'll pass on to some of the challenges. That's what we're here for. And to lead us into this discussion is Henry Cutler. I'll pass on to you.
Thank you very much. I'll just wait for the slides to come up. So I'm Henry Cutler. I'm the Director of the Centre for the Health Economy at Macquarie University. We're located in Sydney, Australia. This presentation is on the challenges and barriers to using outcomes-based funding approaches for health, mostly related to mental health. So this research was funded by the National Mental Health Commission through a grant that we received about 1.5 years ago. It's within a political context within Australia whereby we're shifting from a primarily fee-for-service model to a more outcomes-based funding arrangement and value-based care, in inverted commas. And that has been legislated through agreements that have been made between state and territory governments with the federal government, but also within states. They're also progressing with their own process towards a more value-based healthcare system. This research is part one of 2 parts. I'm going to be focusing on outcomes-based funding. We've also got another component which is on how to embed value into mental health care financing investment decisions, and that explores a framework to think about how to embed outcomes and how to measure those outcomes within an investment framework rather than a funding framework. Both of those papers are available on our website if you want more detail. Obviously, I can only skim over the information that we've got here today because of the limited time we have. So the study itself was primarily based on a consultation process that we undertook towards the 3rd and 4th quarters of 2023. Our aim was really to extract preferences and perspectives of not only government organisations, state and federal, but also non-government respondents, so stakeholders including providers, consumers, carers, peak bodies and academics. We undertook 25 interviews with individuals within nearly all federal, state and territory health departments and mental health commissions. 21 were from state and territory government and 4 was from federal government, which not only included actually mental health commissions and departments, but also some treasury. Oh, can we just go back? And we took 3 2-hour national workshops with 70 non-government stakeholders throughout that process as well, and accepted 12 written submissions. Thank you. Okay, so so in overall, I would say that there was a difference in views taken by government versus non-government respondents. Governments tended to focus on the process of introducing outcomes-based funding, whereas non-government stakeholders really focused on the outcome measures themselves and what that would mean, not only for delivering services, but also as an individual and whether it aligns with their preferences for receiving care or whether it aligns with their preferences for getting value out of the system. All stakeholders generally agreed that needed to be some shift in funding to outcomes-based payment. Mental health in Australia is currently primarily funded through a fee-for-service program called the Medicare Benefits Schedule. And the reason for that was because there was a recognition that the current funding system wasn't delivering the right incentives or delivering the right outcomes for providers to be improving quality of care. There was some concern about how outcomes-based funding models would fit into the current healthcare system. That concern was around governance structures, particularly within a federated system, who would take responsibility. There was concerns around complexity from both government and non-government. And there was also concerns about whether an outcomes-based funding model is the right policy the government should be focusing on currently, given that there are severe workforce issues that also need to be addressed within mental health care, such as gaps in psychologists and psychiatrists, particularly in rural and remote regions. The three key takeaways were that an outcomes-based payment model reform should measure outcomes that matter to consumers or to patients and carers. There should be an appropriate attribution of outcomes to services, and that is really a data-driven approach, and I'll talk a little bit about that in a minute. But also, an outcomes-based funding model should ensure that there is still equitable access to care, and that was a very loud message that came particularly from non-government respondents. So I'll briefly just go over the government stakeholder views. We've got a lot more information in our paper if you want it. But there were 6 core themes that we drew from a thematic analysis of the government interviews. Those were, first and foremost, that needs to be a clear outcomes-based payment model developed within the mental health care system, and there needs to be a clear place for that outcomes-based model. There was recognition that outcomes-based funding models cannot replace fee-for-service models, but it would act as an adjunct, and therefore there needs to be some recognition as to how to focus not only on which service, but also which individual who's receiving care. The Productivity Commission, which is an independent agency in Australia, recommended the missing middle, of which they called those who are not receiving enough services. But respondents actually suggested that there are a range of individuals and services combinations that could benefit from outcomes-based funding. There needed to be continued patient-focused care, so government recognised that the healthcare system does need to be built around the patient. The governments wanted flexibility. It wanted it to promote integrated care and also to promote evidence-based care, so aligning outcomes with evidence and ensuring outcomes-based funding allows providers to deliver evidence-based care was quite important. Again, there was focus on addressing workforce challenges. There was recognition that there were some quite significant barriers to outcomes-based payment reform, particularly around complexity, particularly around sharing risk. So there was a recognition that it does, effectively transfer financial risk from the payer to the provider, and how would the provider respond to that, given that they are now on a fee-for-service model, which effectively has little financial risk. And then finally, there was a theme around embedding appropriate governance structures across government, particularly around responsibilities, but also a question around who would actually develop these outcomes-based funding models. And there was suggestion by some respondents that government, in the way that it's currently structured, particularly in the Department of Health, did not have the appropriate skills or experience to be thinking about how to develop a complex funding model within mental health care. Next slide. So we now go on to the view of non-government stakeholders. And this, as I said, was very much around outcomes. And individuals really felt that the current clinical surveys didn't hit the mark in fully capturing what they want out of a healthcare system. They were very heterogeneous in terms of what they thought was valuable within mental health care, to the point where it was very specific to them. So, for example, improving their relationships with their mother or father, for example, is an outcome that they want, but it may not necessarily be related to mental health outcomes. Ability to function in society, particularly around employment, is another outcome. But of course, that outcome also depends on whether there are employment opportunities and the skill set of the individual. They suggested that existing outcome measures could have limited benefit in comparing outcomes across diagnosis and services. So there are some outcomes that are currently being used that are service and condition specific. And so there was this concern about what type of outcomes could we introduce that could compare outcomes across different types of services. And there was also concern about how do we measure outcomes and use those outcomes in patients that had treatment resistance, where outcomes are in fact not getting any worse. or unlikely to get any better, for example. And there was also a recognition that individuals who were receiving care may be required to receive support to provide useful outcomes data. And there was a recognition that administrative data, i.e. through government that's collected, may help in solving that problem. Next slide. There was some contradiction in terms of what a set of mental health outcomes could look like in a value-based payment system. Some respondents wanted flexibility in a range of outcomes, while others suggested that there should be a targeted and minimal subset of outcomes which could be realistically collected. And in that way, it sort of talks to the recognition that there is a lack of data in the mental health care system. And that's not only on outcomes, but also on all the other services or circumstances that can impact outcomes that are unrelated to the service itself. There was a real understanding that there needs to be accountability for those other types of impacts when measuring outcomes. There was a huge emphasis on the co-design of outcome measurement tools. And there was a recognition that in the past, consumers have really suffered because they've had the weakest voice, i.e. a lot of healthcare system reform is a debate between providers and government. Next slide. Again, there was from non-government stakeholders an in-principle agreement of reform towards outcomes-based funding, and that was recognition of the payment and service fragmentation currently within Australia, the limited innovation in care within mental health care in Australia because of fee-for-service, and the limited encouragement of a holistic consumer-centric approach. There was also an appetite for change, but individuals were worried that there has been attempted change in the past which hasn't been successful, which may also act as a barrier towards outcomes-based funding. They also recognise that there is difficulty in defining outcomes, and there's also low predictability of outcomes, particularly within mental health, because you have all these other factors that impact outcomes that then increases financial risk for providers because they are unable to predict their financial outcomes. Next slide. Respondents noted that there might be perverse incentives if there was to be a focus on specific outcomes. So, for example, providers just going through a box-ticking exercise to meet outcomes rather than delivering holistic care to the individual patient. There was a suggestion that providers may focus on individuals who are likely to achieve better outcomes rather than those who are the hardest types of cases. And so that's a recognition of a potential cream skimming of patients. Obviously, that can be accounted for through risk adjustment. But again, we come back to the issue of data and how do we risk adjust with limited data. And there was also a recognition from some providers that outcomes-based models could be perceived as offensive and role devaluing by providers, and in some ways take away or at least negate their intrinsic drive to improve outcomes. So in terms of the overall discussion, there was support for outcomes-based funding, but potential implementation barriers. One of those in particular was defining value. So value for whom and for what? Value is defined differently when you talk to government compared to when you talk to a provider, compared to when you talk to an individual. There needs to be measurable outcomes that matter to consumers, and there also needs to be investment in reducing data scarcity. There is recognition that there is complexity implementation, particularly around within a federated government structure, but also complexity in getting providers on board. And there is a problem in that there is currently little evidence of the potential benefits of outcomes-based payment models, particularly within mental health care, that can drive providers to participate in effectively what is a more financially risky endeavour for them. There also needs to be the tension between what is most important between all stakeholders and that tension must be managed if implementation is successful. Thanks.
Thanks, Henry. Now, on the following slide, we have an opportunity to once again engage with our audience and ask you for your reflections on what are the key takeaways of the challenges of outcome-based financing for health. And if there's any in-room participants that want to raise their hand and see if that relates, Neil?
Yeah,
so just maybe just wait.
Neil Stanworth, ATQ Consultants. I've evaluated a number of health SIPs in the UK. I think they do work. So if the person who thinks they don't wants to come and talk to me afterwards, I'll put them straight. I was interested in Henry in what you found, because it struck me as you were going through that a lot of the challenges you were enumerating were challenges to accurate outcome measurement in any environment. They're not really outcomes value based, relating them to value. It struck me, is this a fair takeaway that whether or not you go down that line, it sounds like there's quite a lot of work to do to improve the measurement of mental health outcomes?
Yeah, no, I completely agree. I mean, if we look at the broader healthcare system and you think about outcomes-based funding, a lot of that has been applied to very discrete episodes of care. So, for example, hip replacements, knee replacements, whereby an individual comes in, receives a service and leaves. There's not much that sort of impacts that outcome unless an individual decides they want to run a marathon 2 weeks later. But with mental health and also all other social care programs, the complexity is, exponential. And the only way that we can deal with that complexity is if we move back from an outcomes-based to more of a process outcome type arrangement, whereby we have a relationship between a process and an outcome and we rely on that relationship. Or we go down the pathway of investing a lot more in data and our analytics of data. And Australia is doing that. We've invested a lot in government administration data linkage, but our recommendation within the report, and we make several recommendations for a government to introduce outcomes-based funding, is to say, actually, you can't just rely on data that's currently being collected. It has to be purposefully collected data to measure outcomes and to measure those other things that may impact outcomes.
Wonderful. Thanks, Neil. We have Carolyn, yeah.
Hi, I'm Carolyn Henrik from Vanderbilt University. I was struck by something you said, Emily, when you were describing the outcomes that you were studying in your particular social impact bond. And the long-term outcome, as it was described, was 13 weeks of employment. And I was thinking, have we really shifted in thinking about what's long-term? Because that's still a probationary period, 3 months for most employees. I'm just curious, because I do understand this tension between needing the data, as we were just talking about, to be able to measure these things. But I mean, research in general shows that about 70% of people who are going through difficulties getting employment will lose their job in the first year. So 13 weeks seems like a really low bar for thinking about wanting to have a long-term impact. I don't know if others had thoughts on it. It's just the complexity of this particular area, and given that that's sort of a tangential outcome to health. Yeah.
Exactly. Great question. I think if we kind of go back to the cohort of severe mental illness, a lot of this cohort has never had a job. So the fact that 3 months for us perhaps seems quite short term, but for someone who's never had meaningful paid competitive employment, that 3 months is revolutionary, life-changing. And so I think, that is the main point. I also think that secondarily, some of the providers' kind of complex data systems of capturing this kind of sustainable outcomes once the client is no longer perhaps engaging with the service, there's a high drop-off rate. There's not many people that are sending in job slips or, picking up the phone, because once they've gained competitive employment, they go, I don't need to engage with the service. Thank you so much. I want to make sure that my frontline staff worker or caseworker has time for other people. And so there's a drop off. So I think there was an experimentation of 6 months. And I know a lot of providers are starting and trying to innovate to collect this. but the ability and kind of culture of evidencing outcomes still has a lot of work. Perfect. We'll just move on to the next presentation, but we have a panel Q&A very shortly. So next is Ruben's presentation. So take it away, Ruben.
Thank you, Emily. So I want to share some insights about the health impact bond Standing Strong from the Netherlands. I see there are some investors in this impact bond in the room, Bridges and BNP Paribas. So please share your point of view if you want to, or disagree with my my lessons learned. But actually, what we are struggling right now in the Netherlands is how to go away from the pilot phase and really entrench impact bonds into systems, and especially the health systems. And actually, that's quite difficult. And my main takeaway, I will share it and then I will explain, is that there's a very positive business case in preventive health for individuals, so individuals benefit, also for a society, so the society as a whole benefits, but not for individual players, and especially not for outcome players. And that's what I want to show in the next 5 to 7 minutes. But first, let me tell you a bit about the health impact bond Standing Strong. So in the Netherlands, but in all of the Western world, people get older, and so people fall down also more often. It becomes more and more of a problem in most jurisdictions. And actually, that's a problem. You cannot solve it totally, but there is enough evidence that there are good interventions to help people from falling down. And actually, if you train people, if you build their muscle strength, if you do exercises, already in a 3-month period, you can see in the next year, they fall down 43% less. And that's international proven. So it's actually quite a no-brainer that we fully invest in prevention. But on the next slide, so here, but in the Netherlands, actually, there's not much seniors who do these kind of trainings. So, and one of the reasons, and Bridges, like that's also in the UK, the case, is that savings are really scattered. And in the Netherlands, it's scattered among municipalities, health insurers, and the national government. So they all sat down at the table, and we agreed in the northern part of Limburg, that's somewhere in the south of the Netherlands, that in the coming 5 years, we would screen 7,000 seniors. So we invite them for a fatality session, and then they get a screening if they have a high risk of falling. And then around 1/3 has a high risk of falling, and we invite them to the course. And those courses are given by local physiotherapists. And then we follow the seniors for 2 years, and we see whether they fall less than they fall down before the course. So that's the impact bond in a nutshell. On the next slide, you can see how that goes. Like, so we screen them, we do the intervention, and we measure the results. And we do that through, like, we have a regional coordinator who is responsible for the program. And then every municipality has its own local coordinator, and the local coordinator makes sure with all the health workers that enough people are recruited and getting the course and are monitored. Yes, it's okay to the next slide. These are the parties involved. So on the outcome payer side, we have 7 different municipalities. Then we have CZ and VGZ, and they have 90% of the population are insured with those 2 health insurers. And we have a Zorgkantoor, and that's a very complex institution I don't want to talk about. But it's they also receive some of the savings if people fall down less. So, and then you also see the people who do the intervention, the SPV, which is managed by Social Finance NL, and Deloitte, who's doing the monitoring. And then we have 3 investors, BNP Paribas, Bridges, and also One Planet Crowd. And One Planet Crowd is a crowdfunding platform. So also individuals could invest in this impact bond from 200 euros onward. So that's a low barrier. So then on the next slide, the history of this SIP. So the idea already started in 2013, 11 years ago. But actually in 2019, we really found a region who really wanted to work with us, and we could really build a business case and find the investors, etc. And then in 2022, it was launched. So the first results you can see on the next slide. So actually, first of all, the individuals really like the course, and it's not only that they get training, but it's also a social event. So there's a coffee and biscuits, and they really enjoy it. They gave an 8.2, and that's for Dutch standards. We are quite critical, quite high. And 80% of participants also indicate they experience benefits from the program. So that's pretty good. And now we can measure the first effects. Of course, it's quite early, but actually we expected a 43% reduction, but it's now 65. There's quite a fade out effect, which we anticipate, but we are quite happy with the first results. So on the next slides, some lessons learned. So in the picture, you can see the Minister of Health visiting our program. It's the one in the middle at the back, not the one falling down. Although she fell down a few months ago politically, but that's another story. Yes, it's true. When we worked on this impact bond, also nationally, there was a discussion what should we do with fall prevention, and there was a big subsidy to all municipalities to invest in fall prevention. And on the one way, it was a bit awkward because we just created an impact bond, and now there was also another way to invest in fall prevention. But on the other way, like it's good. I think we have really good evidence, or we can create really good evidence to compare the traditional way of investing in fall prevention and an impact bond. And what we actually already see, and I think that's the biggest benefit, and it was already mentioned earlier with one of the speakers, is accountability. So we know exactly who is in the program, what their age is, what their how many falls they had in the past. We know the dropout rate in the program. We know the number of physiotherapists and how much they charge and whether they have the right license. We know, and of course we follow the participants, and we can really work with that data. So we have a steering group every quarter. Municipalities are always represented by the aldermen, so by the political leadership. And those 70 municipalities are also looking at each other because they also have a role to play in executing the intervention. We have to reach their citizens, and if one or two municipalities are lagging behind, they really have a tough conversation with each other how that's possible and how can we solve that. So that rigor into this program, that's really different than what we see in other parts of the countries. And now we are also executing this program, not with an impact bond, but we do execute the same program, but it's funded different in other parts of the Netherlands. So we can share our methodology. So yeah, I think that's the main benefit. With respect of time, I will continue. On the next slide, you see some of the data and how we work with the data here. You see recruitment in 3 municipalities, and then on the next slide, you can see some our budget in the 7 municipalities who work with us. But let me go to how I started, and that's the question: how we can ensure it's not a pilot anymore, but how can we really entrench outcome-based finance into the broader health ecosystem. So on the next slide, Like I told in the beginning, there's a good business case for the individual, there's a good business case for society, but there's actually not a very good business case for the outcome payer. So now we ask them to be involved in this project and spend a few million, I think 4 million max. But if I would ask them to spend a few billion, they wouldn't do that because it will really hurt their bottom line. And that's because there's no business case for prevention in the Dutch healthcare system. And I know it's also the case in other jurisdictions. First of all, we have a system that an insurer with a healthy population will get less money, or they have to hand over money to an insurer with a not healthy population. So if you make your population healthier, you have to give that money actually to your competitor with a less healthy population. Then second, so with the hospitals, actually their strategy is to keep costs at hospital low, but they just make lump sum agreements with hospitals. So they say to a hospital in Amsterdam, okay, you're allowed to spend 300 million euros a year. So if that hospital spends less on an operation, a hip operation, because of there are less full incidents in that area, then probably they will find other ways to spend that money to get to 300 million. And if they are above 300 million, it's their responsibility. So that's why also the insurers first said, okay, please talk to the hospital because they save money, we don't. But the hospital didn't agree. And then third, and that's a reason, that's a reason mentioned a lot by health insurers, but I shouldn't buy it. They say, okay, our clients switch health insurers. So if I invest in prevention, I do the hard work, I pay, and then they switch to my competitor with a cheaper health insurance, and they get the benefits. Actually, we looked into the data. Around 90% of Dutch people don't switch health insurer. It's only that 10%, and those 10% are young people often, so they're not our target group. Anyway, so these are reasons why like the insurance do like to work on an innovative project, on a pilot, but it's really hard to convince them to really change the way they work and change the way the healthcare system is financed. So what to do about that? So first of all, the health insurer must be rewarded for successful prevention. That's clear. But also what we see right now is there is a lot of appetite for investors to really invest in outcome-based finance in health. Also the Dutch pension funds, but also our national promotional bank, InvestNL. So I think and we work a lot with them, but now our task is to really with them convince central government to make the market work for outcome-based finance. And last, and Monday we will publish a report in how outcome-based contracts can be entrenched in the broader system. And we also interviewed the US, and they have an ARPA-H program. It's about a big program about innovation in health, and they use outcome-based contracts in those billion subsidies. So also the Dutch government really, because there's not much investment in prevention in health, they gave huge subsidies to try to turn that around, and also those subsidies should be outcome-based, and then I think you can really change the ecosystem and not only do pilots. But I hope I could share some insights on our health impact bond in Limburg. Thank you.
Thank you so much, Ruben.
Yeah.
Perfect. So now we'll move on to some Q&A. So please raise your hand if you have any questions. But first, I'd like to direct a question to Balázs Nagy. With the outcome-based contracting or financing for health, obviously there's been some suggestions that this can be used to scale up evidence-based interventions, can be used to reform for innovation, particularly with areas of need such as mental health commissioning in Australia, as well as increasing incentives for quality of care and performance. How can this value matrix that you've been created for decision makers on weighing up different definitions of success or different definitions of benefits, how can this be operationalized?
Yeah, thanks for the question. I hope you can hear me.
Yes, really.
All right. So it's, I don't know if you can go to the value matrix because it's easier to answer it this way. Oh, that's great. So the intent, yeah. So what you see here is that this is a work in progress, but this is designed for each different sort of financing mechanism. So it's not only for SIBs, but for other mechanisms as well. It can be created, and this is the case for outcome-based contracting. And it's of course can be subject to criticism, but I think it's a good starting point to as a step to understand the motivation of the different actors in this when you are setting up the whole system. So what you see that we marked with yellow the commissioner, which in this case quite often the government, and the investor, which can be they can be quite different actors there with blue, and if both of their interest is the given value, then you see this in green, and what you see on the left hand side that we are starting from the financial aspects to the societal benefits. This is a sort of scale. Just to have a better visual on from what kind of returns, what kind of values we are heading to, what kind of returns, and the way we think we could use this matrix, and this is what we are planning in the Invest for Health project, that when we are sitting down with the potential actors in the finance mechanism that is being set up, like it can be a social impact bond, but can be also other different arrangement. And we would like to take these actors through this matrix and check what are their direct interest when setting up the given system. So, what you see here that in the case of SIBs, investors' interest is of course financial returns. It's not the only. And what you see in green is that there are other interests as well. And if you go down, then it looks like if you are heading towards the societal benefits, it's more of the interest of the commissioner. And once you are able to understand the motivations, then you probably arrive at the designated finance system that may be SIB, but maybe some other kind of financial instrument to find the potential investors. So that's the way we are planning to use this one, but we are very happy to receive more comments on this. This is, as I said, this is work in progress. Also, you can see that there are overlaps between the different dimensions of value, because of course the quality adjusted life here can be incorporated another value elements as well, and then the other way around. But at least it's a great, because what you see quite often that the actors, they have some intent, but they don't know what kind of financial instruments are around and how they can achieve their goals. And once you are able to map these, then you are better in designing the system. So this is the short answer to your question.
Perfect. Thank you so much, Balázs. And the second question I want to ask to my panel is, it seems that there are some successes of outcome-based funding for health, and it seems like there's quite a building appetite to use these approaches for healthcare system reform. I know, Ruben, your report was just released, and Henry, you have some great papers on this. What would be your key sort of recommendation on increasing capacity and system infrastructure to allow more of this approach to happen in healthcare systems?
Would you like to go first?
Yes. So first, the financial business case should be sound, which is now a problem. But what we see actually is also a lack of knowledge. So not every country has a GoLab or academic partner. And we see, like stated already this morning, that civil servants and governments change a lot. So a center of expertise outside government or within government would be very useful to get more outcome-based contracts into the system. Yes, and lastly, like legislation. So right now, it's really hard to get an outcome-based contract, especially because of how we budget. So we budget per year, and it's really hard to budget for several years. So if you change the legislation a bit, so it's easier to budget for outcome-based contracts, that you can really make multi-year partnerships, that will be very helpful.
Yeah, so data. That's that's the pathway towards outcomes-based funding, because what data does is it reduces uncertainty. And I noticed within that values framework, there were two actors, but typically the most powerful actors are providers. And you can mandate outcomes-based funding, but you're not going to get very far if you have a BMA, for example, pushing back. So you need to be able to convince providers that this is valuable to them. And when you don't have data, and when you have a huge amount of uncertainty around outcomes, you have a huge amount of uncertainty around financial risk. And if they can't manage that financial risk because they don't have the data, and if they can't interpret that data, even if they do have some, then it means they're not going to participate.
Now I'd like to open up for Q&A from our audience. So if you have a question, please raise your hand. We have one from Anders at the front.
Hello, my name is Anders Bak Mortensen. I'm with GoLab and Roskilde University. And thank you very much for a great series of presentations. I really enjoyed it. And it made me think about the value of overcoming these challenges. And therefore, I'd like to ask the panel, what do you think is the most convincing piece of evidence, anecdotal or scientific, that outcome-based financing is indeed a good strategy tool in health?
Great question. Who wants to start?
I can start.
Yep, of course.
So, personally, I think outcomes-based funding promises a lot because we know, even from a theoretical perspective, that if you're within a healthcare system, particularly a market such as mental health, and there is some uncertainty around outcomes, then a fee-for-service model isn't appropriate, and there needs to be some sharing of risk in terms of financial risk. You look at the literature, and outcomes-based funding is called many things. Pay for performance, for example. In the US, we're now looking at bundled payments and accountable care organizations. But if you look at the literature, it's almost 50-50. Half of them work and half of them don't. And you might as well just flick a coin up in the air to see whether yours is going to work or not, because the literature really doesn't give a framework as to what a good outcomes-based funding model looks like, because it has to be specific to your service delivery, your political climate, and your market structures. So, the greatest sell, I think, would be to gather more information around the capacity for outcomes-based funding to deliver better health outcomes. But if I was being cynical, it would be, if you wanted to sell to government, to demonstrate how it can save money in their budget.
Absolutely fantastic. Any more questions? Yeah, from the back. We've got one just there.
Sorry. Toby Eccles from Social Finance. I guess the bit that was coming across to me here was that there's a lack of definition of use case at times. And therefore, because of the lack of clarity of whether are we growing knowledge, are we demonstrating we can operationalize something within government systems, are we just transferring risk at scale onto providers and hoping that somehow electrifies them into providing better services. And I was just interested in testing with the panel, both whether that's also something they would agree with, and whether, certainly with the mental health piece, I'm really interested, what is the use case really? Is it just transfer of risk? And whether clarifying that use case would actually generate things that might scale, because my nervousness with the scale pieces is so often, as you say, government's just looking to save money. And then you've got cynical providers just trying to work out how to buck the system, and they 50% of the time succeed.
Yeah. Does anyone else?
We also. So that's what we experienced, especially in the beginning. Government just said, okay, it's a good way to save money, so let's do it this way. We started in the financial, like when there were deep budget cuts within a government. So the main question is I don't think that we shouldn't say to them, okay, we have, like in the Netherlands, we have 18 impact bonds and 12 are successful, so let's go on with it. Because it's a successful impact bond doesn't mean, like a successful intervention doesn't mean it's a successful impact bond. The question is, does it work better than when we contracted it in a traditional way? And that's really, really hard to prove. But two things. One, and that's what we see in the Netherlands with the fall prevention case. I'm not sure how it is into mental health. I don't have any experience, but there's really a lot more rigor in the impact bonds I work with compared to programs which work in a regular way. And with those impact bonds, when there are also some impact bonds without any rigor, they're just as stupidly designed as normal contracting. But that's because there's not enough budget. There's not, like they say, oh, that's all too expensive, and that's for management and consultants we don't want to pay, and that's okay. But then I always tell them, like, some things we do with impact bonds is not because we want an impact bond, but you should do it anyway. You should be very clear what the outcomes are, how to monetize them, how to measure them, how to agree with each other to have active performance and improve the intervention. That's not something with impact bonds. Like, also, if you don't use an impact bond, you should do that in order to get better results for your target group. So often they think it's a very expensive tool, but that's, like, good government is expensive.
Perfect, thank you.
Can I add one more?
Yeah, of course.
Just about thinking, maybe if we switch the expectations and believe that, okay, let's develop SIPs and test innovative interventions, but not the contracting is the innovative, but the intervention itself, and prove that it's better than what we used before, then we can integrate it into the public budget and the public governance scheme. Just the intervention will be improved. That may be another proposal.
And we also have an online question. So if the person wants to unmute themselves, but if I can summarize it correctly, it's a question to Balázs and to Stefania. There was a suggestion from your presentation that SIBs may work well in areas where outcomes are more defined, such as in hospital care. But this online participant suggests that perhaps that's not an area that would necessarily generate healthy return on investment. And they're wondering if they could elaborate further on this use case.
Let me, okay. Go ahead, Bill.
No, you can.
Okay, I can take it. So I think that's a fair question. So what I think makes a SIB successful, and this refers to the previous question as well, and I don't have the evidence. I just, we have done a number of interviews as well and went through the literature, great literature, and I just heard your presentation that were confirming that the time horizon is quite important. If you have the benefits are coming in a short time horizon, it can be said to be successful, but it, of course, it still depends on the measures and how you set the bar, etc. But and if you have a long-term like outcomes that we are not fit to the structure of the SIP for sure. And if it's getting back to hospital care, there you can have some short-term benefits. If you think about prevention, it's not easy to have, especially for secondary, primary prevention, it will not work. For tertiary, it can work. That's what Stefania said as well. And also about the risk sharing element, that was the previous question as well. That if you are able to identify how to share the risk and find a bar that is manageable but still need to, you are incentivized to go through, then it will probably work. But as Henry said, with the 50%, it may happen that in 50% of the cases the bar was just too low, and this is why it worked. And in other cases it was just too high. And just one more add to what Rubin said on that their case, I think, is quite successful because they have very short-term outcomes, like whether the person falls or not. That's a great outcome for a SIB, because if it's primary prevention, okay, they will not eat. They will eat healthy food, and in 20 years they will not get cardiac problems. That cannot be fit enough. But falling happens just straight in the next year or not. So I think these factors, like how you set the outcome and how you negotiate, what is the process of getting to the outcome, and this is why we have the value matrix, so just to find the right motivation, right outcome, and what is the time horizon you are expecting the outcomes, and maybe the time horizon that you have related to the process-based outcome. This is what Henry said. I think these are small steps forward to get to a good SIP.
Perfect, thank you. So that concludes our panel Q&A. I'll go to the next slide, which will have something on next steps. Hopefully we can continue this conversation. I know that there's numerous questions we must have. So please follow up with our speakers, Stefania, Balázs, Henry, and Ruben, as well as reading the reports and papers that they've created, as well as the ones on GoLab website. Tonight, we have the launch of the Peterborough's to Kirklees report, which is synthesizing 15 years of evolution of outcome-based contracting in the UK. And collaborator Alec Fraser from King's College, as well as myself, have a paper or an article on there on scaling up evidence-based healthcare using a social outcome partnership. Tomorrow at 8 a.m. in working room 4 on level 1, we also have another health session, which is solving global issues in women's health with partnerships. And that is with our fantastic collaborators at the South African Medical Research Council just there. Additionally, we also have a podcast episode coming on outcome-based financing for health, so stay tuned. And finally, we have an Engaging with Evidence webinar on the mental health project. So please join me in thanking all the panelists and all the audience for such great engagement. So there should be a feedback survey on the last slide. So if you have any feedback for us, please give it. We are really happy to continuously improve. Otherwise, there is the lunch break in Enorme Forum. Thank you.